This meeting is being recorded. If you have any objections to that, please disconnect now. David?
Okay. Well, everybody, welcome to the meeting. Sorry, we're still on Zoom, although it is good to see everybody's faces. We are hoping, all things considered, to get back to in-person meetings starting in March. Both the March and April meetings are going to be moved to the fourth Friday of the month. In the case of March, because of hymns, and in the case of April, because of Passover. So you'll get an announcement about that. But as I say, we're hoping to be able to do that as caseloads go down, and certainly in Nelson Mullins, they're having larger meetings now. We may have to meet at a room that's different from the one we've used in the past because the rotunda room is being renovated. That's almost finished. But the AV system so far is being held up due to supply chain issues. What, big surprise. But we're hoping that meeting room will be available as well. So that's a look ahead. Jim hosted a terrific meeting of the program committee, and he'll tell you what we have in mind for future meetings, but we have a number of really interesting topics. So Jim, I'll turn it over to you at that point.
Okay, I'll be very brief. I'm going to push ahead to April and then come back to March. We had a really interesting call this morning with Nick Vanderheyden and his team and some of the folks at George Mason University, and we're trying to put together a program for April on virtual nursing, which is an emerging concept that's apparently starting to get some really interesting traction. We still have an open slot for March. So we have a number of things coming up later spring and early summer, but we have not yet finalized a program for March. So you'll have to wait for this announcement, and you may be subject to the dreaded phone call from David or me or someone else asking for more input or more suggestions. But we're looking for that. We've got some candidates, and we'll look forward to talking more. But I'm really excited about the topics we're going to cover today. So I don't want to take any more time. Let me turn it over to Joe to introduce the speakers and pass it on.
Great, thanks, David. I only have to pass it on to Lloyd to introduce the speaker. Okay. And carry on. If anyone does put a chat in the box while we go, I will make sure that the speakers are aware of it, and I'll let Lloyd tell us when we're going to take questions. Lloyd, off to you.
Okay, well, I was just going to say, you've already got the biographies of the people who are here, and since it's actually two current professors and one ex, we tend to run long. So I'm just going to get to it. So let me check. Do you have? I'm going to share my screen, and if you've got that, I'm going to start my slideshow. You see? Can somebody confirm you're seeing?
Yes, it's up.
Okay, great. So I'm going to talk about dashboards for supporting public health needs. It happens that the idea that you're going to have a public-facing dashboard is one of the innovations from our current pandemic. However, the first time you do anything, it winds up needing work. And right now, what you get from Fairfax County in Virginia, which are the two places I'm focusing on, they really just present raw data and don't support the department's messaging. Messaging, which is their primary goal, such as please get vaccinated. And they're particularly bad at health equity issues. They've been providing breakdowns by race, which for a large population county aren't terribly helpful. There's no why, there's not explaining why is it that Latinos are worse off than Black people without some kind of small area drill down to census data. And I'm going to close off by identifying there actually are high quality curated data sets that will be useful in dealing with these problems, and they're going to work with BI tools you probably already have. These are Fairfax's two dashboards. The one on their left is their COVID dashboard, which is giving you cumulative numbers. That is the number of everything from day one of the pandemic. And the one on the right is their vaccination status dashboard. How many doses were administered? How many people got one shot? How many people are fully vaccinated, which they are still defining as having gotten 2 doses, not having gotten 3. I'm just saying, hey, this information wouldn't convince anybody that they should go out and get vaccinated. Here's an alternative presentation that does. This was put together by WakeMed, which is kind of the ANOVA of the Raleigh metropolitan area. And they've taken a completely different approach to providing quantitative information. This is something that's called an icon array, and they're simply telling you, these are the number of people that are hospitalized with COVID, and they're breaking it out by vaccinated or unvaccinated status with the helpful tip, you need the vaccine. Let's compare these two things as to what information they chose to present. Fairfax is providing case counts. WakeMed is telling you about the number of serious cases only. Fairfax is giving you cumulative data. WakeMed is giving you current data. Fairfax's dashboard doesn't actually say anything about caring for people with COVID. WakeMed is breaking out several different levels of care that has a natural progression from regular hospital room to ICU to ventilator. Fairfax's dashboard doesn't actually say anything about vaccination. WakeMed's, you have a vaccination impact breakdown. Now, there really is nothing wrong with Fairfax's dashboard. That's something that's useful to management, and it would really be BI malpractice if they didn't know what the cumulative number of cases or deaths were. WakeMed is aiming at data that is specifically useful to civilians, and they're trying to present them with honest information that is useful to them in reaching the decision they hope they make. Fairfax went for strictly numeric presentation. WakeMed went for visual, and the specific presentation for Fairfax was something that's known as a KPI card, and WakeMed went for icon arrays. What do I think is good about the WakeMed graphic? Well, they're encouraging vaccination by focusing on bad outcomes, which is what people really tend to worry about. You know, you've heard anti-vaxxers saying things like, well, the death rate isn't very high, so why should I bother? It goes, well, how much would you like to be on a ventilator? It's a well-designed data viz. It actually shows a lot in a small space. They've got 3 levels of care intensity, and frankly, they could have added another colored dot to show the number of empty beds they have, if any. And icon arrays have been shown to be a pretty effective antidote to base rate fallacy. I mean, they're giving you the ratios right there, so you don't need to worry about people forgetting to count the false positives or something like that and walking away with a misleading impression. Furthermore, given that we're operating in an environment in which people don't trust people in authority, it's not asking the viewer to trust a hidden calculation. Rates and ratios can be misleading, and people just looking at a particular ratio might go, why should I trust this person? Finally, this is bound to a meaningful geographic area. Wake County, North Carolina basically is the Raleigh metropolitan area. They're not doing what happens on some other things I've seen where they're presenting average information for a large diverse state like Virginia or for the entire country. Now, the point here from a BI theory point of view is that different stakeholders legitimately have different needs. Figuring out what each of your stakeholder communities needs and what form you should present to them is at least as important as getting the data in the first place. Clearly, you have to get the data in order to present it to them, but that doesn't get you all the way there. And one of the things you should be doing when you're coming up with dashboard design is doing things like focus groups and talking to the various NGOs that are going to be communicating with those populations as to what it was that you can communicate that would really convince them. I mean, how likely are bad outcomes? How long am I likely to be hospitalized if I needed to be hospitalized? Maybe what's the likely cohort? How long is this long COVID business? Right now, those numbers are not openly available. And even if they were, it would be fairly hard for a civilian to find them. And I'm noting that there really isn't a tradition of providing public outcome measures by local departments of health. What do I mean by outcome measures? Well, here's one. This is from the Dartmouth Atlas of Healthcare, which puts out reports of outcomes that are largely based on, not largely, they're based on Medicaid billing data. So this, for example, is showing regional differences in leg amputation for Medicare beneficiaries with diabetes. It's well known that lower extremity amputations is one of the major negative side effects of having diabetes, and you don't need to explain to anybody why that's a bad thing. And as you can see, there are big regional differences. Then they took those regional differences and put them into two bee-swarm plots, one for Black folk and the other for non-Black folk. And you can see, you can just eyeball this and see that there really is a health equity issue here, in which the best hospital referral region has a black person amputation rate that's about equal to the median for everybody else. Don't know why, but that certainly is an interesting result. Let's move on to health equity issues for the Fairfax Health District, which is Fairfax County plus the cities of Falls Church and the city of Fairfax. Now, this is doing rate ratios in which they're comparing the experience for 3 different racial groups divided by the white experience. Frankly, this is not the best design because having more hospitalizations is bad. Having more vaccinations is good, but they're putting it on the same scale. But you can see from this that a number of things that are interesting for which you don't have more explanation, such as Latinos are actually more likely than white folk to be vaccinated, but have really bad outcomes. And in fact, the hospitalization rate for Latinos is twice as bad as for Black folk. Why? I don't know. This is the limit of the explanation we're getting from this dashboard. But just to do kind of a check, I went and looked up the same thing for the Lennowisco Health District, which is 3 really poor places in the southwestern tail of Virginia. So these are 3 Appalachian counties, one of which has the worst opioid death rate in the entire state. And here you can see that the racial differences are diminished. And it goes, well, why is that? And I'll equally tell you, I don't know. But it does seem like there is a difference other than simply being of a particular race that is affecting health outcome. I think it has something to do with the fact that those are places where nobody's doing real hot financially, but it's an interesting thing to check. So I want to take a moment to talk about what I call the inadvertent statistical gerrymandering problem. There's a technical term for this that is not terribly helpful, which is that most health open data is published by county. And the top 100 counties have 43% of the United States population vast internal diversity. There is absolutely no relationship between the number of people that live in a county and the land area of the county. In affluent places, such as Fairfax, and this is something that replicates in almost everywhere for urban counties, people move to cities because historically, because economically it's been good for them, make more money. And that's true for poor people too. Fairfax is only 6% poor. And part of those poor people are GMU students who you expect to be only temporarily poor. But given the high population, that's 70,000 people. 70,000 people where right now the FPL is around $12,000 for single person and $23,000 for family of four. So given the cost of living in Fairfax, that's really poor. There are two possible solutions to that kind of gerrymandering problem. One is to use smaller, more homogeneous uses such as census tracts. Zip codes are second best. The other is to use business-related geographical units such as hospital service areas, which is something the Dartmouth Atlas came up with, in which they're attempting to approximate hospital catchment areas, which are, hospitals are important in healthcare. Let me give you this example of county distortion. Both of these maps are showing exactly the same data. It's the 2016 presidential election results. The one on the left is a choropleth, which is known as a fill map if you're using Tableau, in which you change the color of the entire county from red to blue based upon which presidential candidate won the election in that county. The one on the right is something called a dot density map, in which you fire at random a dot for each 5,000 voters. Every 5,000 Donald Trump voters get a red dot, Hillary gets a blue dot, and other. And if you take a look at Utah, you will see there is a noticeable green tinge because of the third party candidate that was a former Utah governor. I leave it to you to decide which is more accurate. They're both accurate representations of the data, but they sure do look different, don't they? Let's move on to the CDC Social Vulnerability Index maps for Fairfax County. This is what I mean when I say that in order to understand health equity issues, you really need to go to smaller areas. Fairfax has own, and you can imagine if you're only making $12,000 a year, you don't have a lot of places that have housing that's affordable to you. And in fact, there are two large concentrations of poverty in Fairfax, one just south of Alexandria along the Route 1 corridor. The other is in Bailey's Crossroads, and there's three other blobs. And you can see just by looking from the colors, most of this is yellow, which means these are people in the top quartile. That particular collection of data breaks out along four different dimensions: socioeconomic status, housing type, household composition, and a combination of race, ethnicity, and languages. The Social Vulnerability Index is taking 15 different variables off of Census's American Community Survey, and it's organizing them in four dimensions and creating an index number for each of them and an overall index number for how vulnerable it is. And as you can see, socioeconomic state is very, very compact, mapped mostly into those two neighborhoods I mentioned. Housing type, you can imagine if you're poor, you're much more likely to be in multifamily housing, can't afford a single family house. And that data is all readily available in completely public. You don't need to worry about copyright government data sets. And I want to let you know that the BI tools you already have actually have more geospatial capabilities than you might think. Tableau, Power BI, and Excel can make maps using both point data and custom polygons that you can import in. Tableau and Power BI can call R or Python and external map providers. And I'd note that in days gone by, BI tools didn't do maps or any kind of geospatial analysis. You needed to spend a lot of money on ArcGIS. Also, modern high-end databases like SQL Server, Teradata, Oracle, support spatial SQL and a polygon data type. So you actually can do a bunch of geospatial queries without having to use a GIS at all. Like with SAS, ArcGIS is the SAS of the geospatial world. There are now high-end open source alternatives. And since somebody's going to bring this up when you talk about small neighborhoods, HIPAA's limited dataset rule does authorize small area analysis. You just have to sign a data use agreement in which you promise not to do things you shouldn't be doing anyway by trying to re-identify the data. How does this stuff work? Basically, you're using location as a universal key, in which you're using case count data to look up neighborhood demographic data from census and CDC places. What should you wind up doing with this? I suggest the first thing you should always do to have a better understanding of your health equity issues is to create what we call in BI a dimensional model in which the count data is the fact table, and you divide the other variables into dimensions, preferably with some kind of drill down, like from year to month to day. Statistically, there are statistical techniques for running regressions off of count data. You should be aware that a lot of these social demographic variables correlate with each other. So if you're asking questions like, are you poor because you have a job that doesn't pay very much, because you don't speak English, because you didn't graduate from high school? Those things all correlate. Here are, and if you ask me to send you, happy to send out the PowerPoint slides, the URLs are in here. Two things that you can link to by zip code are the ARC social determinants dataset and CDC places, in which the CDC, there's a thing called the Behavioral Risk Factor Surveillance System, where they have used small area estimation techniques to break this out by zip code. CDC Social Vulnerability Index, also available. And finally, the Dartmouth Atlas of Healthcare, that's a Dartmouth, has both crosswalks and shape files denoting hospital service areas and hospital referral regions, which is super useful for organizing healthcare into business reasonable units. Online tools I wanted to mention before I'm done. If you want to do health equity in a hurry, you cannot beat the spatial data equity tool from the Urban Institute. I'm not going to talk about these two because I'm running out of time. Conclusion, departments of health should figure out what vises sell and work backwards from that. You should really focus on the needs of the NGOs who are doing the shoe leather outreach, which is how this stuff gets done. Develop a robust dimensional model that incorporates census and behavioral risk factor data and deliver it to them in the BI tools they're used to using, which is most likely to be Excel. I thought COVID dashboards were actually a great idea. Let's do this for all the major chronic conditions. In my career, nobody ever asked me to put any census or BRFSS data into the data warehouses I was building for Medicaid. I think they should have. And I'm going to stop share here and move over to Dr. McLaren. Have I?
Can you see my screen?
I can.
Great. I'm Zoe McLaren. I'm an associate professor at the University of Maryland, Baltimore County, and I'm going to talk about innovation in health and healthcare and use the specific case of COVID-19 rapid tests. There we go. So I want to kind of take this case study and help you think a little bit more about how we can make new technology available to the public, specifically in the health and healthcare realm, which has a lot of barriers that aren't necessarily present in other realms. And we're going to focus on the COVID-19 rapid testing, so these are the at-home rapid tests. And I'll focus on their kind of 5 broad barriers to widespread use, and then lead to 3 lessons for the future that can be applied both to this situation and others. Just really briefly what my background is. My degree is in public policy and economics, and then I was on faculty at the University of Michigan School of Public Health. So my work encompasses economics, public health, and mainly focuses on data analysis, although that's a little bit less of what I'm talking about today. I work on infectious disease policy, and I've worked on HIV and tuberculosis and have been mostly working on COVID-19 since the pandemic began. And my work involves a lot of big data, doing statistical analysis. I've gotten into some machine learning, and really with a focus on decision-making under uncertainty. So thinking about the data we have and what can we learn from it when we don't have perfect data. So I think about this data evidence policy pathway and figure out what data we have available, figure out how to crunch those numbers and get evidence that can then inform what policy should look like. And I spend a lot of time building this bridge between the data we have and the policy guidance we want, because oftentimes the data we have is imperfect, missing data issues, we don't have the coverage we want, we don't have the local area data that we want, and we still need to come up with policies. We can't just wait around for better data to become available. So my work involves a combination of statistical methods, mathematical models, just real world insight and shoe leather, getting down on the ground and thinking through things. But today, what I'm really going to focus on is, once you have that policy guidance, what's that last step of kind of getting the policy guidance to actually be implemented? And so with rapid antigen tests, there was pretty good data pretty early on that these were effective tools. They had one job and they did it well. So that's a headline from me writing in Fast Company. That was mid-August 2020. And I'd gone into all of the published literature and through all of the modeling and everything, and kind of determined that there really was strong evidence that these tests worked. The antigen tests were widely used for other diseases, for example, malaria, and there was a lot of kind of uncertainty around them, but that didn't match up with the fact that we had good evidence. So what were the barriers? So we had a little bit of this paradox. So we had this great new technology that had one job and did it well. The technology in the middle of a pandemic would save a lot of lives and save a lot of money in terms of avoided lockdowns, avoided hospitalizations and deaths. But there was very low demand overall for these tests. People were not banging down doors, getting access to the tests. There was a lot of concern about accuracy and whether they were worthwhile. And then there was also fairly low supplies. They weren't kind of very widely available. And the policy was really, really slow to respond to bring this new technology to the market and to the public, despite these pressures. So trying to think about why that is. So there are 5 barriers, kind of broad barriers that I've identified to widespread use. And so the barriers all interact with each other. So that kind of 2 barriers interacting creates more than the combination of each one individually. And what we're focusing on here is the barriers to widespread use. The idea with rapid tests is we want them to be widely available. We want people to be testing themselves frequently. And so when we think about kind of what level of testing is required, it's not like, oh, okay, well, if I need a test, there's a way I can figure out to go and get one. We want them to be easily accessible so that people are just using them in general. And I've used that word widespread because I think it kind of communicates to the public what we were aiming for, kind of this ubiquity. So the first barrier, which is always inherent in any kind of innovation, especially in the tech field, is that there's uncertainty and risk. And this barrier kind of augments, magnifies all of the other barriers because decision-making is really much more difficult when you're facing uncertainty. So we didn't know exactly how the technology was going to perform. There was good academic evidence that validated the tests, but of course there's a human error component. We weren't sure how people were going to interpret the test results. So there was kind of a lot of concerns about kind of accuracy and how that would work. We weren't sure who was going to bother using it. Would people be willing to test or not? And then in terms of who benefits, so it wasn't clear. A lot of the benefits of testing are not to the person testing themselves. It's to their family and their community. And so we have these diffuse benefits that are really hard to measure in the first place and hard to hard to identify. Of course, it was also really high stakes. So nobody wanted to kind of invest in rapid tests if it was going to end up being a dud and not help us control the pandemic. And then of course you have risk aversion. So when there's a risk involved, people tend to be risk averse, organizations tend to be risk averse to various degrees, and that's going to lead to some kind of paralysis. The second barrier was there was very kind of low perceived demand. I'm using that word perceived to suggest that there really was kind of latent demand, that if people understood the value of these tests, they would want them. And so what we were seeing is that just it didn't seem like people were really demanding them, that they weren't able to communicate that. So part of it was people didn't fully understand how the test worked. And that meant that they had pretty low trust of this new technology. So familiarity often breeds trust. And so there was that breakdown there. There weren't very many good ambassadors for this technology. So I was a little bit surprised to see that the big drug companies were not going out and pushing for these rapid tests to be more widely available. It ended up being kind of a small part of their portfolio, and they weren't really focused on public education the way they might have been around other types of drugs that you see there's commercials on TV for them. And a lot of experts, and this is some of the conversations that I had, were really worried about their own personal credibility. So they didn't want to advocate for rapid tests, and then it turns out that the rapid tests weren't effective and their credibility was damaged. So experts were really hesitant to talk about the rapid tests, and often focused on the shortcomings, more on being a cheerleader and focusing on the overall benefits of rapid tests. Again, the benefits were unclear and diffuse, so people who purchased and used the rapid tests were not necessarily the primary beneficiaries of those test results. And then, of course, there were price barriers. So there was a fairly restricted regulatory environment as well. So this is always going to be the case with new technology. The regulatory environment was developed before this new technology was, and it tends to be fairly risk averse and slow to adapt. And here the main player was the FDA, the Food and Drug Administration. And so we expect the FDA to be risk averse. They don't want to give the green light to a product that then turns out to be ineffective or cause harm. And we also have the issue of there being both overregulation and underregulation at the same time. So it wasn't really one or the other. So the idea that the FDA needed to be fully hands-off didn't make a lot of sense because we wanted it to be approving more tests. But if you think about building demand and building trust in new technology, you do want the FDA to be regulating to provide that validation and to engender trust among the population. The fourth one was that there was a limited supply of tests. We weren't kind of swimming in tests. So the main reason for this is that there are very low profit opportunities in the United States for the companies that produce the tests. So there was that low demand, right? So it wasn't clear people were going to buy them. They would be willing to pay much money for them. There were, of course, the regulatory barriers that could have prevented them from bringing new tests to market. That was a big barrier. And then also concerns about obsolescence. So this idea about we only need testing until the vaccine was approved, and then we would just switch over to using the vaccine only, which I think was a big kind of an unforced error there. We know we need rapid testing at every stage of the pandemic. And this idea that we had this Operation Warp Speed and lots of subsidies for vaccines, but we needed those same subsidies and coordination of the supply chain for rapid testing as well. And the fifth major barrier was that there was a lack of political will. So this was not a big priority among the Trump administration. And when Biden came into power, it was a lot of experts expected it to be a big priority, and then it wasn't for one reason or another. We don't know exactly who had that kind of influence. But we know that elected officials are responsive to public opinion. And so part of it was that there was low demand among the population. And so it wasn't clear that the administration, it was worthwhile for them to invest their limited political capital in this kind of risky new technology that the public may or may not be interested in using. And so this is also how this uncertainty can be paralyzing, because people weren't sure if they wanted to use the tests, and elected officials weren't sure if improving the regulatory environment was actually going to lead to more tests and more widespread use. You can end up with this kind of paralyzing process. Okay, so we have these 5 barriers. And so if you're thinking as an expert or somebody who wants to increase widespread use of these tests, which barrier do you want to address first? Which of these do you want to address first? And so what ended up happening, and I've spent a lot of time on Twitter, which is where a lot of the COVID experts would have lots of conversations in the direct messages and things like that, talking about these things. And the general consensus on Twitter among experts and people was that the way to start was with the regulatory environment. So that was the major focus from the middle of 2020 through the fall of 2021. So what did that accomplish? So people were kind of pressing the FDA to authorize more rapid tests. It was, we need more tests to authorize. The FDA is the main bottleneck here. So what ended up happening is in the fall of 2021, we actually had 9 authorized COVID rapid tests. So 9 different tests, including Abbott's Binax Now test, which was one of the first ones that was authorized for home use, still appears to be one of the most effective tests, and is sold in other parts of the world under the PanBio name. And so it's been able to produce a kind of pretty low cost. So we had several authorized COVID rapid tests, but you still could not get access to rapid tests. There were major shortages. So that was clearly not the main bottleneck that needed to be addressed. So we spent a lot of effort yelling at the FDA, and it didn't get us very far. So instead, where could we start? So what happened in terms of the turning point with rapid tests? So what happens, there was an increased demand for rapid testing during the Delta wave. So that was the last summer and the beginning of the fall. People had gotten vaccinated, and then people who had been vaccinated were getting infected with Delta. And so we realized that the vaccines were not going to be enough. We needed some additional tools, and demand for rapid testing started to grow. So what that drove is that the White House kind of developed, influenced to develop the political will to make rapid testing a little bit more of a priority. So what did they do? They had a big initiative in September where they lowered the price. So they had several retailers provide rapid tests at cost, so lowering the price. And then they did some additional subsidies and free distribution to increase the supply. And then they also reduced the risk and uncertainty. So by the fact that they were getting more involved, they were distributing, that they were focused on the price, they were showing that these tests were useful, that there was demand for these tests. They showed a willingness to be more involved in the supply chain, which would suggest higher profit margins for the producers as well. So that was the big turning point. And the key was that the turning point was driven by the increased demand from the population. People realized the value of rapid tests. They learned more about rapid tests and decided they were accurate enough for the job that they were meant to do. And then that was what ended up driving the relaxation of some of these other barriers as well. Okay. And then the most recent development was the free home delivery of rapid tests. There was a covidtest.gov website where everybody could log on and order 4 rapid tests delivered for free by the US Postal Service to their house. It wasn't per person, it was per household. So that free home delivery garnered a lot of media attention. So that media attention alerted people that rapid tests were still important, that the government believed that they were useful, that people could get them to try them out. And so the government buy-in to this whole rapid test program builds trust among the population. It's a very clear signal that these tests are worthwhile. And so a lot of people who may not have trusted the test before would be willing to at least order the free ones to try them out or have them on hand. So if they're free, people are willing to try them, have them around, and get a sense of whether they might trust to use them in more high stakes situations. And the data that just came out a few days ago is that about 45% of all US households ordered free rapid tests online, which is really, really high demand compared to some of the numbers people were saying last year. And people are kind of saying, no one's going to want these tests. Nobody wants to get tested. No one sees the value of these tests. No one wants to quarantine, isolate, things like that. So really, and the idea with that 45% is that because there was this barrier of having to go online and order them, that there probably was another 20% of the population that would be interested in rapid tests, but just didn't get around to requesting them online. So that was a pretty clear signal. And the White House had said that they were looking for a signal. They were kind of trying to gauge demand. And that's a really, really strong signal that there is robust demand for rapid tests. That was just latent. It was kind of hovering beneath the surface. So what are the 3 lessons from this whole COVID rapid test scenario? The first is that public demand drives everything. There are a lot of barriers. So we listed 5 of them, but of course they're very broad. So there is policy doesn't kind of rapid test new technology doesn't just happen on its own. It needs a lot of shepherding through the process from a number of different players. But public demand is going to drive all of that. It's going to drive the elected officials, which are going to drive the regulatory environment, which are going to drive, which is going to drive the business environment as well. So really demand is the place to start. So if you have new technology and the public doesn't recognize it, or your particular users, if it's a healthcare technology that the clinical providers don't value it, don't recognize it, aren't demanding it, then it's not going to necessarily happen. It's really hard to do this from a top down because of all the uncertainty and risk involved. Any way that we can reduce uncertainty and risk really pays dividends, because that is one of those barriers that interacts with all of the other one and magnifies them. So maybe the elected officials really recognize the value of rapid tests, really want to control the pandemic, but there's this uncertainty about, like, they can invest a lot into it, and is it going to end up paying off? There's so many moving parts. So the more that we can reduce uncertainty and risk, the better. And a lot of that uncertainty and risk, the best player to reduce that uncertainty and risk is the government. So there was a real big push among some people in the rapid test to say that we wanted the government to kind of take its hands off the rapid test situation and let the market do its thing. But what we find especially in terms of public health and also in healthcare, is there's too many frictions in the market for that to really be effective. And what I tell people to focus on is the vaccine playbook. Whatever we did for vaccines, we didn't just let the market take care of vaccines, right? There's general agreement that the government needed to be involved in vaccine access. We need the same playbook for rapid tests. And what does that look like? That is an Operation Warp Speed for rapid tests. They work directly with the producers. There's guaranteed purchasing. There's helping with the supply chain, all of those types of things. There is a public investment, so signaling to the population that the government trusts these rapid tests. That helps improve trust among the population. There is subsidizing. So our vaccines were all free. Rapid tests should also be free. They serve a very similar purpose in terms of controlling the pandemic. And making access really easy. So having home delivery of rapid tests or making it really easy to pick them up. And then also a strategic stockpile. So we have a strategic stockpile of vaccines just in case it turns out we need a new set of boosters with the next variant. We should have the same for rapid tests. We should not be facing nationwide shortages. It is a kind of a very strategic misstep to not have a strategic stockpile of rapid tests. The same playbook we use for vaccines, we should also be using for rapid tests. And with that, thanks so much for your attention. I'm happy to take questions later on in the session.
Do you see my screen?
Yes, we can.
Yes, we can.
So I think my topic is slightly different. I'm going to talk about depressed patients and how artificial intelligence can help them. But the real purpose of me coming here is because I need your help. When I see a business roundtable, I think, oh, these people know about business, so I should go to them to see if they can help me. So at the end of my presentation is a plea for you to help me. This research was funded by Commonwealth Health Research Board of Virginia, by Robert Wood Johnson Foundation, Optum Health, and Academy of Health. This is really a work of a number of people, and I shouldn't take the credit for it. I would like to have a shout out for Dr. Wojtuziak, who developed was primarily responsible for our web space, and Dr. Coffin, who did our marketing, and all the students who helped us in numerous steps. We have a very different vision of how healthcare should be delivered and what is healthcare. I think that doctors have given up on artificial intelligence and alerts. They're turning them off. And I think they are too busy, and computer hasn't really succeeded in changing their behavior. Our vision is that we provide artificial intelligence directly to patients, to consumers of healthcare, and they take it to their physicians. And physicians and clinicians pay attention to their patients, not to computers. And patients care about their health, so therefore they want a more accurate diagnosis, a more accurate treatment, a more effective treatment, if they can find it. So our goal is to provide information directly to patients. And we want to create a clinic that operates in that fashion. I'll come back to this issue of clinic later. Management of depression is a mess by any standard. I'm an engineer, so I can't stand healthcare because everything in healthcare appears like a mess to me. But here is some extraordinary things that are happening in depression management. Majority of patients who take antidepressants don't benefit from it. Majority. That's ridiculous. Thousands of studies on the effectiveness of antidepressants have been done, but they're all small samples. Or most of the negative results have not been published. In fact, a recent paper showed that if the negative results were published, prescription effectiveness would be considered not effective. These are FDA results that were submitted to FDA, but not submitted for publication. And finally, almost all of these studies are not pragmatic. Sicker patients, patients with particular medical histories are excluded from these studies. And we don't know what is effective for them. We don't know what should a cancer patient take for depression. We don't know what a psychotic patient should take for depression. The only thing that exists is a tier-based clinical guidelines that says there is tier 1 and tier 2 depression medications. These guidelines have not been validated. They are not followed. I mean, to me, it's like ridiculous. Genetic profiling is not helpful. And decision aids that codify these unproven guidelines and experts' intuitions are being produced, and these things are not reasonable. If you start with something that you don't know is effective, and you know from evidence that clinicians are not good in prescribing antidepressants, and you codifying it, that's not reasonable. So what did we do? We studied 3.6 million depressed patients. We analyzed 10.2 million treatment episodes and saw what was effective in these treatments. We were able to organize 16,700 patient subgroups in which different antidepressants were effective. And this is the basis of how we are recommending antidepressants to patients. Here is a simple difference between average clinicians' prescriptions and the decision aid if it was followed. As you can see, the decision aid is better for all age groups. On average, the decision aid is 17% more effective. The decision aid is far more effective for sicker patients. Our decision aid was created recently. This slide shows various images. We do describe our background to how it was developed, why it was developed. We ask about 10 to 15 questions on the medical history of the patient. And based on that, we provide an executive text-based recommendation about what should the patient do. We provide some images as well, figures, pie charts, and histograms of which medications or which couple of medications might be effective. And finally, we give the choice to the patients to submit the recommendations to their patient, to their clinician, by providing them with the alias ID number that they can share with their clinician. Our aid is available on the phone. Next, we turned our attention to actually trying this out and seeing if patients are interested in this. We advertise on Facebook and on Google, and for $1.74 per click-through, we found 39 patients per day who were interested in doing this. 39 patients per day. You have to remember that about 50% of people who are depressed have abandoned treatment. On Google, we paid $3 per patient, and we found 15 patients per day. In total, in a period of 1 week, we found near 2,000 patients interested in going through the antidepressant aid. Who are the clinicians who can help us prescribe these antidepressants? Last week, we advertised on LinkedIn for psych mental health nurse practitioners if they are interested to join us. And within a week, we have found 52 psych mental health nurse practitioners with prescription authority interested in doing this. Where are we going? We want to become an online clinic that takes care of depressed patients with major depression, not bipolar, but major depression. There are a lot of examples that venture capital has put money into these areas. And if you look at it, there are also 7 unicorn companies, over $1 billion, that are active in this area. So that's where we want to go. We think we can have the patient demand, and we think we can have the clinicians' interest in participating. And we have an effective way of identifying and asking patients to join this new clinic. What I need from you, and I hope you do this because I'm getting too old and I've come here too often, I need help in organizing this clinic and taking this product to commercial. Let me stop here. Did I go over time or under time?
We're good.
Okay.
And so this is a point at which we're happy to take questions for any one of our three presenters today. Also, if people want to type questions into the chat function.
Hi, Farrokh, it's Richard. Can you guys hear me?
Yes.
Yes.
Great. So Farrokh, first of all, thanks for the presentation.
You're welcome.
So I guess my question is, maybe I didn't quite follow, like, what's the mix of actual online tools and chat boxes or some other kind of fully automated system versus, an initial chat with maybe it's not quite a therapist, maybe it's a nurse, maybe it's a medical assistant. I didn't quite understand what's the balance of that, or is it totally a technology-based interaction first with an automated system?
So the way we are imagining this is like hers.com. Hers.com provides anxiety and depression medications to patients. So the initial recruitment of patients is through a free decision aid, which allows them to see what medication will work best for them. And then they come to a telemedicine visit with a clinician, which is over several periods of time, a real relationship with a clinician. And we want our clinicians to be psych nurse practitioners because they really excel in those relationships. So it is not at all automated, except for the recruitment of the patients and in terms of the decision aids that are used in the care that these clinicians provide. The clinicians make their own judgments and the patient makes their own judgments about what medication is best. We are just providing a decision aid to enhance that, improve that judgment.
Great, thanks a lot. And just to build on that one little bit more, you mentioned a few slides back that the problem is there's a lot of automation, but it's being done for unproven processes or unverified guidelines. Could you just speak on that a little more?
So the Mayo Clinic at University in Florida, the chairman of the psychiatric department there came up with a methodology for a decision aid for antidepressant selection. This methodology is based on the two-tiered methodology of prescribing antidepressants. There is no data that this method is valid, and it will, in essence, duplicate the experience of clinicians because it's based on expert clinician judgment. And that experience we know doesn't work because the majority of patients don't benefit from it.
Thanks.
Yes, so Farrokh.
Go ahead, Jim.
Thanks, Ann. Yeah, so Farrokh, I'm curious whether you, first off, it was a great presentation. It was absolutely wonderful. And you're absolutely, I'm an internist and you're absolutely on point as far as the antidepressant management space is really a swamp. And it's really unfortunate because it is such a big problem. More than unfortunate, I think you did a nice job of handling that. I'm interested in whether you've made a distinction between pediatric depression and adult depression in your public health program.
Yeah, so our data goes for, the 10 million antidepressants that we examine goes from people aged 13 to 89 years old. And most of the 13 to 18-year-olds have very sparse medical history, but there are things like food problems, psychiatric problems that change the recommended antidepressant for that age group. As you get to older adults, it's quite different. You have a very rich medical history and you can identify people with multiple comorbidities, what is ideal for them. There are smaller groups of such patients, but we can identify, for example, a cancer patient should take which antidepressant, or a pregnant patient should take this antidepressant. When you have 10 million antidepressant episodes that you have analyzed, a lot can be said about different subgroups. Up to now, there hasn't been any studies that has 16,000 subgroups of patients. So we have a lot of information. And many of those subgroups are teenagers, many of them are adults, many of them are elderly people, and some of them late elderly people.
Thank you. Anne, and then Barry, please.
Joe, Farrokh, we're on the slide, what we want from you. Can you explain a little bit more what you need to commercialize this or to get this up and running?
So what we need to commercialize this is we need to set up an online clinic, and we need to hire 2 nurse practitioners for that clinic. And we need an electronic health record for that clinic. And then we need to market this to patients and recruit the necessary patients. And my suspicion from the data that I have so far is that within 6 months of operation, we would be interested in selling this clinic to some of the major venture capitals, go to Series B venture. So in terms of what will it take to do this initial 6-month clinic operation, or maybe in hindsight, maybe it should be a year, would be around $500,000. But essentially, all the steps necessary for success of this clinic have been tried out.
And Farrokh, this is Tim. Farrokh, this is Tim. We would also need an instantiation of AWS to handle the back-end infrastructure.
Exactly, yes. Tim is our...
If I can make a suggestion, it sounds like you've got a lot of the part. Doesn't sound like you have a business plan. I'm sorry, what university are you with?
George Mason.
George Mason. I'm going to guess the business school probably has connections to Business Accelerator, can help you put that together. And you certainly have connections to groups. I'm in Maryland. Maryland has a program for a venture mentoring service to be able to have people work pro bono to give you guidance. I'm sure the same sort of thing exists in Virginia. But it sounds like what you need is, it sounds like you got the parts, but you got to figure out how to put it together.
Yes.
I would probably start with your business school and see what connections they have to a business accelerator.
If I can intercede for a moment, there is a gentleman by the name of Josh Green who runs the Commercialization Assistance Program at the Mason Enterprise Center.
Yep.
And this is, he has a very good series of mentors and helps. I send startups to him all the time. So I would urge you to reach out to Josh Green.
Yeah. Let me just say that I have started 3 venture capital backed companies and one of them with the help of David Main. And I'm experienced in doing that. But I think the more important thing is, before we do that business plan, is that I need a manager. I need a person experienced and interested in going forward with this. And if they join, putting a business plan together is pretty straightforward. What is needed here is I need to complete the team that goes to venture capital. And we are in discussions with the George Mason Technology Transfer Organization, as well as I will also follow up with Josh Green. Those are good advice. But we are missing our key members of our team.
Barry, are you still on? Let me see.
Yeah, I'm still on. This is for Zoe. If great presentation. You made the point that it's, trying to be risk averse, trying to evaluate demand before the home test went forward. I was just curious, had any work been done with market research beforehand? Because the whole need to determine demand potential is something that's very common in a lot of other fields. My first background was in consumer packaged goods, and there were well-established test methods and, in fact, research providers that did exactly that, that would evaluate demand. And a lot of that could be done pretty quickly, even in a concept stage, while the product is being developed. So I was just kind of curious if anything had been, if anyone had ever done anything with that with healthcare, like the home test that you were talking about.
So I'm sure that's been done with other products. It wasn't done for the rapid test, or wasn't done in a way that was publicized. And part of that is because the demand was so low that so the market research would have been driven by the drug companies, and the producers, but they were not making this rapid testing a big component of their portfolio. So they weren't doing that demand. The demand, I think it was pretty well understood, demand was low. And then in terms of on the politics side, in terms of the polling, in terms of whether elected officials, members of Congress were getting phone calls from their constituents about wanting access to rapid tests. So there was kind of enough information about the demand to be able to understand that it was low. And then of course, among the experts, we're spending a lot of time on Twitter, for example, and talking to people. And then that you just constantly hear people saying that they'll never work, no one wants to use them, they're not accurate enough, and things like that. So the issue here was not the lack of measurement of the demand. It was that demand was actually truly low because people didn't understand the value of rapid tests, didn't have the vision to see how they could improve the situation, and therefore weren't willing to demand access to them, or didn't have the willingness to pay. So it really was kind of a lack of understanding of the benefits and a lack of valuing this new technology rather than a lack of measurement.
Thank you.
There's another, can you hear me okay?
Yes.
Yes.
Great. So there's another approach that, especially for people who are in academia, who like staying in academia, and this is actually probably starts to get in the bailiwick of part of David's firm, is the whole technology licensing approach, where you go to a teledoc, or you go to, I work for day-to-day healthcare that was just acquired by Babylon Health, which is kind of like a teledoc competitor, basically. So, you go to one of these companies and you say, you have a vision for a center of excellence in, machine learning for, digital first, healthcare offerings. And, and then maybe they work. Now, I know these things, David, can always be tricky, where they make an agreement partially with the university, and maybe the professor and who's doing this is a part-time chief science officer to that center of excellence, but still maintains his role at the university. So I think there are other avenues that can be appealing, where a lot of that business infrastructure, sales teams, marketing, all this kind of research already exists. And so maybe that's another take. I mean, I'd love to hear what David Main has to say on that.
Yeah, I fully agree. There are different ways of going forward. And I think perhaps I have to do all of them. You're right on. David, you want to say something?
David, you're on mute.
I think the options are as we've already discussed. I don't have anything in particular to add. And Dr. Alemi and I have worked together in the past in the startup space. Taylor Devine, I think, was on earlier. I don't see his name still up there, but he's often a good resource in terms of funding.
Yeah. Joe, this is Jim. I've got yeah, I'm unmuted. First of all, all three of these presentations were absolutely excellent. So my thanks and congratulations to the presenters, and Lloyd, particularly to you for putting all this together. I have a question for you, Zoe. I've been kind of dismayed watching progress of the pandemic and the analysis of it for two reasons. One is it seems like we've started everything from ground zero. So a very good friend of mine who's an epidemiologist says we'll have all this figured out about 3 years from now, after it doesn't matter anymore. And our ability to have learned from prior pandemics seems to have been down around zero. We just seem to have not done a good job at all of learning from past experience. My second observation is that almost all of the ideas around best ways forward have become so intensely politicized that if an idea is a Republican idea, half the country hates it, and if it's a Democratic idea, the other half of the country hates it. You alluded to sort of some learning processes of putting a playbook together about how to handle the next one, because this will happen again, maybe in 10 years, maybe in 50 years. But is there any progress being made in figuring out, I guess it's a meta question, how can we take what we've gone through and learn from it and somehow codify those experiences or those learnings so the next generation of people that have to deal with this can learn from what we've done?
So the first part of your question about our failure to learn from past pandemics, we've also failed to learn from the first wave, the second wave, the third wave, the fourth wave, right? Omicron came through, the Omicron wave is down. Everyone's like, okay, guess pandemic's over, back to normal. And I'm thinking there've already been 2 or 3 major variants that have come through. So we, if the past few months is any indication, we should be preparing. And I think the fact that things have become really politicized has really made it difficult both to get traction with ideas, build demand for things like rapid tests and better quality masks, which, and then I think also it's made it really difficult for elected officials. I live in Washington, D.C., and our mayor is up for re-election. And so she doesn't want to get into any of the COVID arguments and has been kind of, relaxing restrictions all over the place in ways that maybe the population is not that excited about. So I think in terms of learning, part of it is, I think, really about kind of framing the decisions that we're making. We're kind of talking about getting back to normal, but the normal is that we need to be preparing for if there's going to, that there is going to be a next variant. We're not sure exactly when it is. And one of the things that I focus a lot in the work that I do, because I have a background in economics, we think about things like the production possibilities frontier. If you've taken Econ 101, that should be familiar. And the idea that we want to look at better tools that are both going to increase the amount of freedom we have and the amount of safety we have. So it's going to keep cases down while allowing us to get back to normal more quickly. And rapid tests was one of those tools that really was one of the benefits of it, that it would keep cases down, but also you could do enough rapid testing and then live kind of a more normal life aside from that. And of course, vaccines do exactly that. They give us a lot more safety, but they also allow us to get back to normal. And the same thing with looking at better quality masks. So in high risk situations, people who want to protect themselves, people who are immunocompromised, can have easy access to high quality masks. One-way masking works, and they can wear their mask, and other people who don't want to wear a mask can choose not to. So it was like when you have a very polarized political situation, then you want to think about developing tools that are going to be able to navigate that. And things like rapid tests, things like just offering plenty of options. Fine, you don't want to wear a mask? How about a rapid test? How about a vaccine? How about extra vaccines? Thinking about those types of things. How about better ventilation? That's one area that we haven't really invested in. So I think part of it is that we have the tools to do it, but there's just, I think it's just been really hard for elected officials when they do something that kind of helps control the pandemic, they don't get a lot of credit for it. And they think, well, what's the point? It's risky. It's a lot of political capital. So I don't have all the answers, but I just think that we have a very short memory and a lot of people are engaging in wishful thinking. I think maybe one of the biggest things we need to do is address the mental health crisis around the pandemic, because I think part of it is people have kind of stopped learning, stopped looking at the situation, relying on wishful thinking, and just has really distorted our collective decision-making.
Could I comment on that as well? I also sort of an economist, and I think you could do a better job at linking up CDC messaging and what they were asking people to do with the economics of what they were asking people to do. For example, if you thought you wanted somebody to quarantine for 10 days after they tested positive, well, in Korea, you can go to a quarantine center, which a number of people did if they happened to live in a crowded living environment. Here, okay, one, did you actually have a job that had sick leave? And it goes, well, Korea would actually pay you your salary while you were in a quarantine center if you did that. Similarly, when it came to, okay, what's the payoff for being vaccinated? Well, in other countries, there's a relatively clear payoff. If you get vaccinated, you can go to restaurants and theater. Here it was just a little more confusing. And finally, I want to mention there are a couple of other countries that are more aggressive about promising to pay for things up front. I think the Australia Health Service has been trying out something they've been calling Netflix pricing, in which they simply say, we want to negotiate a fixed fee per month for what we're going to pay for, say, insulin for the entire country. And whatever it turns out actually be needed, you do it. And if it turns out to be less than you thought, you get to keep the money. I think when it comes to really experimental stuff, the bit about not just taking the risk that it might not work, but the risk that you would have other competitors who are going to fragment the market, I think is a really important problem. And one of the things that governments are actually good at, I mean, it's not just manufacturing things. I mean, to some extent, the whole Federal Reserve System is a risk absorption buffer in finance, is to say, okay, we need to have something happen. We're going to absorb the risk. You guys figure it out.
I also have a question for Farrokh. Farrokh, if I understood your proposed model correctly, you would have patients in effect taking, and I'm kind of summarizing at a very high level, but patients going to their physician saying, I want to take this medication because this research shows that it's more effective. And I like that approach, but then I'm an engineer too. So clearly I'm not, my hunch is that there will be, and we have several physicians that are part of this group today. That rankles a lot of physicians, as we all know. And I'm kind of wondering if you have any experience to talk about how receptive they are or will be to that kind of approach. Joe, you may have some thoughts about that. I don't know.
I should say it was, I think, 3 years ago, we went to dinner, first time, Jim, you and who else was there?
Suniti Pangshe, I believe.
Yeah, Suniti. We discussed this very vague idea at that point. But I think it amazes me that...
and you've taken it a long way, by the way. My congratulations to you and the team doing this.
Yes, it's the team. It's not really me. But my concept here is that clinicians are turning off their alerts. And there is good evidence that they are doing so. And they are doing so for good reasons. These alerts are really problematic. And they are not very receptive to our ideas. We haven't yet tried to see what happens if the patient goes to other clinicians, not clinicians inside our clinic, and presents to them the recommendation, what happens. We are having a proposal that is expected to go out to NIMH in June 2022, in which we will do so. But that part we haven't done yet. There is a lot of pieces that we haven't done yet.
Yeah, and I'll take on the commenting on the issue of alerts with physicians. Kind of a couple of comments. I think the most interesting things I've seen in the last couple of years have come from the Mayo Clinic, and they've rethought the issue of alerts into the concept of providing cognitive support, which is a different kind of a model. There's a wonderful scene in the movie Abraham Lincoln where he's basically saying, trained as a surveyor, a compass is a wonderful way to see where true north is relative to where you are, but that tells you nothing about the path to true north in terms of swamps and other barriers. And I think a lot of times the decision support to physicians has had the same quality. It's kind of been directionally helpful, but is essentially more likely to lead into a swamp, and often an unmarked swamp, in part for the issues you were talking about, Farrokh, in terms of we don't have the data that we need. If there was, when there is data that we need on what's going to be most effective. I did want to get, Lloyd, I wanted to get your thoughts. I loved your presentation. I think I've seen you've been talking about it for the last couple of months. So it's wonderful to see the polish you put on it. I think part of my reaction was that you were showing me Fairfax County, which is absolutely cool. This past Sunday was my cadence day to have a walk with a retired friend. And we typically meet in Columbia, Maryland, because he lives in Roland Park, Maryland, and near Baltimore. And so he said he was going to see whether or not the COVID rates were below 100 per, I think, 100,000 on a 7-day running average basis. And he sent me a graph that had Montgomery County, where I live, Howard County, where we were planning on meeting, Baltimore County, where he lives, and there was another county in there. It may have been Fairfax. I apologize if it was. And it was kind of interesting because Montgomery County had the highest rates, and the place we were going for the walk had the lowest rates. The problem with my enthusiasm for the fact that I was going to a place with a lower risk was that we were probably going to be walking with masks indoor in a mall, which probably makes all of that data completely misleading and inappropriate to use to drive the decision. So I'm just wondering whether you have any reactions to that anecdote.
A couple. One is that the more time I spent with this, the more I get itchy when somebody just spits out rate data and gives you absolutely no information about magnitude. I mean, it's kind of off topic, but I had a conversation with a conservative friend in whom I have great faith. We were talking about violence on airplanes, and he thought there wouldn't be a problem flying down Atlanta. I said, well, the newspaper says the violence rate went up tenfold. That sounds really bad. Now, like I said, I said, why don't I go to the FAA, look up the data? And it turns out that we were both right. That is, the violence rate had gone up tenfold from 0.05% to 0.50%. So that, yes, big problem, but you've gone from having a violent incident from every 2,000 flights to every 200 flights. Doesn't mean it's not a problem, but if you had actually provided people with precisely that information, they'd probably be a lot less agitated on flying. And that's kind of a medical thing too. I mean, we know that mammographies have a fairly high inaccuracy rate. Sure enough, my significant other gets called in for it. And frankly, if you get told you tested positive for breast cancer, it's kind of scary. But at the time that they got it, given the number of false positives for her age group, the probability that she actually had breast cancer was under 1%. And of course, that was not on the test report or the communication from the doctor. And, you know, and so when it comes to all of this kind of stuff, my own mental process is I try and be an informed consumer, you know, read what the guidelines are. I think I sort of kind of understand the physics, that if it's an aerosol infectious disease, it's worth indoors than if you're outdoors. And I just try and say, you know, I'm going to follow the advice and then I'm not going to worry about it. You know, by the way, I haven't been in an indoor shopping mall since the pandemic started, and we spend a lot more time hiking outside.
Yeah, it was 20 degrees, which is that's
another contributing factor.
But to your point, you know, 80% of the people in the mall were not masked this past weekend.
And this was in Montgomery County?
This was in Columbia, Maryland, so Howard County.
Okay, that's a little further. Because frankly, one of the things I like living around here is that most people actually, where I live, you know, which is Fairfax, Merrifield, is that most people actually were masked. And even for the ones that doesn't, nobody's bothering anybody. I mean, I kind of wondered what life would be like if I were, say, in Tennessee or Texas. But it's sort of like, I'm in the right place to be concerned, but not too paranoid.
Yeah. Alabama is my go-to choice for places that worry me.
Actually, Huntsville would probably be okay. I think they have the highest concentration of PhDs in the United States. So
you realize he's just made a giant assumption about people with PhDs. I just feel like I need to point that out. But
Jim, look, you're absolutely right, but there really is a correlation between overall education level and health literacy. I mean, frankly, when it comes to the next pandemic, the thing that has kind of bothered me the most is that I really don't think that the way departments of public health were doing public messaging was really up to. I mean, I can name a few specific people who were really quite good when they were on television, but in terms of actually getting actionable, I mean, I hate the term actionable insights, even though I'm BI and I'm supposed to be saying this all the time. This bit about, you know, are you giving people information that is relevant to them that they can actually use to make a decision about what to do? Oh, we haven't been doing a great job.
We keep talking about the next pandemic, but we're still in the first pandemic, and there's still like people, it was the same thing with rapid testing about a year ago. People said, well, next pandemic, we should be better on rapid testing. And then we stopped putting any effort into it. So I think the idea that we can just revise things as we go, we need to be working on it for this pandemic, makes a lot of sense.
And finally, I mentioned a terrific Ezra Klein column from about a week or two ago, in which he pointed out that the countries that had the highest rates of vaccination didn't have mandates because they didn't need to. People trusted the government. The government told them that they ought to be vaccinated, and they were. It would be nice to get back to that. Historically, there were absolutely no problems getting people to take polio vaccines in the 50s.
Yeah. So it's 1:30. I'm going to declare victory for this group session. I'm going to stop the recording, and I'm going to leave the conversation open for anyone who wants to continue. So thanks everyone for joining, participation, fantastic presentations from everyone.
Okay, Zoe, Farrokh, and Lloyd, do we have PowerPoints of your presentation?